Hi, I'm Andrew Einstein, a cardiologist at Columbia University Medical Center in New York, and it's my pleasure to welcome you to Molecular Imaging Highlights from the American Heart Association Scientific Sessions in Orlando, Florida. The American Heart Association Scientific Sessions is one of the world's leading cardiovascular meetings. There are about 25,000 people here to share the latest news and advancements in cardiovascular medicine. And we're talking about some of the latest advances in cardiology medicine, and in particular, focusing on molecular imaging and molecular medicine. I'm happy to welcome Larry Fine from the National Institutes of Health, the National Heart, Lung, and Blood Institute, to join us today, in particular to hear your perspectives on the SPRINT trial, which is really one of the most remarkable trials that has been published in many years from my perspective. So thank you so much for taking the time to join us today. Can you tell us about the SPRINT trial?
So the trial involved 9,300 people, was testing two blood pressure goals: a standard goal of 140/90 and an intensive goal of 120/80. The trial was stopped early because the DSMB, Data Safety Monitoring Board, found evidence that there was benefit in the intensive treatment group. Benefit in two ways. The primary outcome of the study was heart attacks, heart failure, strokes, and acute coronary syndromes. And that was reduced at the time when the DSMB looked at the data in August by 30%, highly statistically significant. But also was that total mortality, all-cause death, was reduced at that time by almost 25%. Since then, we've added some more. There are cases in the pipeline that we've continued to adjudicate and add to the data set that went into the New England Journal article that's being published today. And the reduction in heart attacks and heart failure and stroke is now 25%, still very statistically significant. And actually, reduction in total mortality is a little bit greater, it's 27%. So the combination of having the reduction in what we call the primary outcome measure and total mortality led the DSMB to recommend to the Institute and our partners, there are three other institutes who are also co-funding this with us, to unblind the investigators and to notify the participants. And then we began working very hard to prepare a scientific report, submit it to a good journal, and it's been published today. Those results, I think, really affirm the importance of identifying high blood pressure, treating high blood pressure, and getting good treatment or control of high blood pressure. But the exact way that that SPRINT results will be incorporated into guidelines, is really for the guideline committee to consider, and I'm sure they'll do that carefully. In our study, patients who were in the intensive control group, on average, were on 3 high blood pressure medications. Patients in the standard group were on 2, so there was one difference in a medication. One extra class of medication was used. We used medications like diuretics, ACE inhibitors, calcium channel blockers, the types of medications that there's the strongest evidence for before the study that they would be effective.
So right now what you're suggesting is some sort of shared decision-making process between patients and their doctors if their blood pressures are in this intermediate range between 120 and 140 now?
Well, so I'm glad you've asked me that question. So let's talk about who was included in the SPRINT trial. So number one, you had to be over 50 years old. Number two, you had to have a blood pressure of at least 130 millimeters. Number three, you had to have some evidence that you were at high risk of cardiovascular disease or heart disease, and how much you get that risk. So one way was, some of your viewers probably know about the Framingham risk score, very common risk score that we use to calculate risk. You had to be above 15%. And what that means is that your risk of a heart attack or some other event like that was more than 15% in the next 10 years. Or you had to have chronic kidney disease, or you had to be over 75. Just because age is the one risk factor we don't know how to change, and older people have higher risk of heart disease. So if you were in one of those three groups, you were eligible to be in the SPRINT trial. So it didn't cover it. So those are pretty broad, what we call inclusion criteria, but it didn't include everyone. For example, it did not include people with diabetes. It didn't include people.
It excluded people with diabetes?
It excluded people with diabetes, excluded people who have already had a stroke, and excluded people who have a fairly rare kidney condition called polycystic kidney disease. And the reason was, at that time, there were ongoing NIH-funded studies. So we were trying to sort of study a different group than those studies were. And to me, I think a lot of providers and patients will wait until the guideline groups have had a chance to weigh all of the information and come to a judgment. But I do think even when that happens, your point is a good one, that this is an individual decision between a patient and a provider about what's best for an individual patient. Do they want to take the extra medication? Now, one question that you raised was what to do about the patient maybe whose blood pressure, maybe they don't have high blood pressure, maybe their blood pressure is 135. So we did have some of those patients in the trial. The most common patient in the trial started the trial with a blood pressure of about 140 on 2 medications. So the vast majority, and we really haven't calculated exactly what fraction, but the majority of patients in the trial were people with hypertension who were already being treated. So the results are probably most applicable to them, but again, the guideline groups are going to weigh all of these different issues and decide what specific recommendations to make.
In any event, it sounds like this is a real game changer,
right?
In terms of making
I
us
think
rethink
right.
high blood pressure.
I mean, what I think is that there are a few situations. LDL cholesterol is one, and now I think you can say this about blood pressure, in which we have a lot of epidemiological evidence that suggests lower is better. And the SPRINT trial affirms that lower is better, but of course there's a second question, which is a very important question. How easy is it to get lower? So if it's easy to get lower, then the SPRINT trial would encourage one to think about getting lower. If it's more challenging, more difficult, or maybe a patient says, I don't want to take another medication, doctor, that's a different situation, and so so that's how I tend to look at the results of SPRINT.
Mm-hmm. You know, we're discussing lots of fascinating research which is being presented here at the American Heart Association scientific sessions. Ultimately, what is the role of research in advancing cardiovascular health?
Well, you know, I think the role of research is to point out the strategies. Some of those are lifestyles, like the DASH diet. I mean, for example, we know in blood pressure that if you lose weight, if you eat a diet with lots of fruits and vegetables, if you avoid excess alcohol, if you get regular exercise, that you can lower your blood pressure. In fact, you can lower your blood pressure as much as taking a blood pressure medication. So let's say you are a patient who was in SPRINT on 2 medications, you came into the study with a blood pressure of 140, your alternative is not necessarily to take the 3rd medication. Your alternative could be to take the DASH diet, which may not be easy to do at first, but is a diet high in fruit and vegetables, low-fat dairy products, minimum amount of meat, lower salt diet. Those can have the same effects, actually, as taking that 3rd medication. So I think what the research does is it shows ways forwards that both patients and providers can reduce the risk of heart disease, and in many cases, and that wasn't what SPRINT was so much about, of course, treating a heart attack or heart disease once you have it.
What is the role of the NIH in fostering medical research in the United States?
We have a broad role. We like to have a broad spectrum of research that we cover, from genetics to clinical treatments to lifestyle factors. But we like to talk about discovery science. In other words, our number one mission is to fund individual researchers like yourself who have a good idea and want to pursue that idea to add the scientific knowledge.
Larry Fine, thank you so much for joining us. This is really groundbreaking work, which you and the National Institutes of Health have fostered, so I congratulate you and your colleagues on this tremendous advancement in medical science.
Okay, thank you. I just, in closing, want to say that we should also have gratitude for the 9,300 patients in the study. We had 500 staff. So it was really a collective effort. And one thing about these big clinical trials is everyone gets a piece of the glory, but there's no one single person who's really responsible for the whole thing. It really is a collective effort. Thank you very much for having me here today.
Thank you so much.